very much. Again, note down your questions. Now, we've had some talk at this conference about courage, and I think we now have Daniel in the lion's den. So I wish you courage. This is Paul Whelton. He's here to talk about the new guideline.
Actually, there are many aspects, particularly Dr. Jurgensen's talk, that I completely agree with. I spent most of my life battling with the food industry, and they don't like me.
Okay. Pull out the back.
What am I doing? Yeah. Oh, I see. And then I can get rid of it. Yes. You should really have some slightly more confident.
I'm not confident. Okay. There we go. Now, Great, so my invitation, and let me say how very pleased I am to be here. My invitation is to talk a little bit about our 2017 ACC, I call it ACC AHA blood pressure guideline. I have no conflicts of interest. I've chaired a number of the trials that we have been felt to be important when reviewing the materials for the guideline. I chair the guideline writing committee. I will tell you this is a guideline that American College of Cardiology and American Heart championed, but they spent about a year trying to encourage others to participate, and we had a wide variety of groups in the US that are involved in the care of high blood pressure participate. We spent a great deal of time trying to get the family physicians to participate because, in my opinion, it's always nice to have everybody under the same tent and try to come up with some common entity. I won't go into the details of that, but a lot of offers were made, and then at a very late stage one night, we were informed that the family practice group were publishing their own guidelines the next day, so it just didn't happen. But we had a very good committee, 21 members in the writing committee, multidisciplinary group, including 2 lay patients who were very, very helpful in our thinking. Nobody had a conflict of interest. In other words, nobody was allowed to participate in that committee if they had any commercial relationship with a pharmaceutical company or with a company producing devices to lower blood pressure. We had an independent review committee. I won't go through the details of the process, but I will tell you it's very structured. It is largely based on the Institute of Medicine's recommendations for, we've had a series of recommendations, as you may know, how to develop guidelines, and our most recent one was 2011 Guidelines We Can Trust. It is a comprehensive guideline, so it's long, but each of the sections and subsections are written in exactly the same format, so it's relatively easy it's written such that it would be relatively easy for a healthcare provider to get specific information on a topic of interest. There are a lot of recommendations, 106 formal recommendations. There is a lot of evidence presented, if one cares to look at it, including 448 detailed evidence tables. And we did try to identify what we thought were the importance of each recommendation, in other words, class of recommendation. And we also did try, despite what was said earlier, to try to give our understanding of what we thought the level of evidence was. It was a fairly serious matter. We may not have gotten it all right. Not everyone has to agree with what's in a guideline. It is a guideline. And this guideline is written for the US, where control rates for high blood pressure are at a very different stage than what they would be in Europe, and certainly very different to other parts of the world. And I think particularly when it comes to looking at risk and risk factor estimation, the tools will not necessarily be very transferable. There's some things in any guideline that are very transferable from one population to another, but risk prediction is not one of them. Our guideline underwent 2 years to prepare it, and then a year for feedback. And we sent it to individuals around the world. But I guess for me and for others in the guideline, it was important for us to reach out to our colleagues in Europe and Australia and Canada and other parts of the world and get their inputs and try as best as we could to have a guideline that within reason would be as similar as possible to other guidelines. In fact, the European guidelines, which will be presented and published next week, have some semantic differences, but in their base recommendations, they're very, very similar to ours, which is a good thing, because we're all looking at the same data. And then the guideline underwent extensive review by the participating professional societies and was approved by their governing bodies. Sorry. Get out of that. Here we go. So let me just talk about a few aspects. Blood pressure measurement is, I think, a key aspect. It is the elephant in the room. And I say the elephant in the room, which is a term we use in the US because it is not really taken seriously, but it is a huge issue. And that's where I believe a lot of overdiagnosis occurs in practice. Now, we know that blood pressure, unlike measuring weight or some other factors that we measure, is very variable. We have very careful and rigid quality controls for our laboratories. We shut them down if they're not within standards for how they measure creatinine, cholesterol, and so on. We wouldn't fly in a plane where a pilot said to us, I've got a series of recommendations before we take off, but I'm busy today. I know you want to get to your destination, so to hell with them. But in clinical practice, we have a very, what's the right diplomatic word for it? We have a capacity to ignore recommendations. Now, we have known, when I trained very early on in my career from Ireland, and I trained with Jeff Rose at a very young age, and one of the things that was well known then 40 years ago was variability in blood pressure. Pickering had asked Rose to look at it, and he had identified the factors that will predictably or systematically influence your measurement of blood pressure. And we know factors that will lead to a false understanding of the average level of blood pressure, and we know factors that relate to random variation and averaging. So we have known the factors that we've got to deal with for a long time, and guidelines have recommended how to measure blood pressures to get a best estimate of the true average that a person was being exposed to. And most of the risk estimation studies and the clinical trials have used blood pressure measurements that are closer to guideline recommendations than are used in clinical practice. So if one believes in evidence-based medicine, then one should be measuring blood pressure in pretty much the same way as been done in most of the risk estimation studies and most of the treatment trials. But unfortunately, that is not occurring. And we don't take it seriously in medicine or in the other disciplines that deal with blood pressure. It's not something you ever get in an exam. It's not something when people come to certify offices, practices, clinics, hospitals. It's not on the agenda, and it should be. So we spent a lot of time focusing on that. It's nothing new, but we know on average, when we look at the sort of measures that are typically done in practice in the US and in other countries, on average, they tend to be about 10 to 15 millimeters higher than when you do it according to what's recommended in any set of guideline recommendations or any scientific statement from professional societies. So there's a lot of overdiagnosis that goes on, a lot of overtreatment that goes on. So one of the key things we recommended was accurate estimation of blood pressure. We stuck with the brachial because, one, you can get very valid measurements there, and two, it's at heart level. You can get valid measurements at the wrist, but it's not usually at heart level, and people tend to swing the wrist. And the wireless measurements at the finger are on many apps on iPhones and so on, but they're virtually all very inaccurate. Proper positioning, rest period, valid instrumentation, cuff size, no talking, slow deflation rates if you're doing auscultatory measures, which few people do these days, and averaging more than 2 measures on more than 2 occasions. So we felt that was very important. That's where I would say the overdiagnosis comes in. We also, like many recent guidelines, suggested that it was a very good idea focus on office measurements because that's where the data is for the clinical trials, but it's also very, very good to look at what's happening outside the office because we know there are a lot of differences. If you see sustained high blood pressure in the office and out of the office, then it's very easy to understand what to do. It's more challenging when you see white coat hypertension high in the office, low outside, or masked hypertension. Masked hypertension may be a little easier because they seem to have very high levels of risk, very similar to what you see with sustained hypertension. White coat hypertension, studies vary. There was a very big Spanish study published recently that suggested a high level of risk. So at the moment, we're in the awkward position. We don't have any clinical trials here, and you have to make recommendations based on expert opinion. Now quickly, classification of blood pressure and thresholds for initiating treatment. Classification of blood pressure has been going on for many years. The first really true formal classification system came in with JNC4 in 1988. Has been part of virtually all subsequent guidelines. It is useful. It is not biological. The body doesn't understand hypertension. There's no such thing. But it's helpful if you're trying to make decisions as to who should get particular attention with non-pharm, who should get the combination of non-pharm and drugs. So it's a pragmatic definition, and it's traditionally in blood pressure been based on some combination of risk and understanding that there might be a treatment benefit. And typically, we have used the term hypertension where there seems to be evidence both of increased risk and the benefit of treatment. Now, in the US and in most parts of the world, since about 1993, we have used a system that is the one that I showed here that was used in JNC7. Less than 120 over 80, normal blood pressure, over 140 and above systolic, 90 and above diastolic hypertension. When we looked at the data, we felt this was appropriate. We kept that terminology. We also felt 140 and above was appropriate. We kept that terminology. Where we ran into an uncomfortable situation was this so-called pre-hypertension, which in Europe is called high normal. We didn't like that term because it suggests to a person that I don't have hypertension, I'm okay. I don't need to worry about it. If you say high normal, you say, well, I'm normal. I may be high, but I'm normal. We didn't agree with that. We thought, particularly at the upper end of that distribution, that it was more appropriate and fairer to an individual to be told, you have hypertension and there are things you can do to reduce risk. And the problem with labeling comes when somebody is told you've got a problem and there isn't something that can be done. You do not see problems with labeling where somebody is told you have a problem, but there is a solution. And problems vary from saying it is milder to saying it is very severe. So why did we use that terminology of stage 1 hypertension? Well, we used it for 2 reasons. One, the risk was elevated, and 2, we thought that interventions were beneficial. So whether you look at cohort studies, where you usually start with a relatively healthy person that doesn't have the outcome of interest, or you look in clinical settings, you will see the same basic thing. There is a progression of risk. The body doesn't understand hypertension. It's just risk increases. It does so at all ages, a little steeper where you have more likely to have a single risk factor when you're young, and a little less steep when you're older where you have multiple risk factors. But it occurs for systolic blood pressure, for diastolic, for men, for women, for any country you care to look at. Now, if you specifically look at the 130, 139 group, risk is elevated, even in studies where you get volunteers, and it's typically close to an increase of twofold in risk of stroke, heart attack. And if you look at populations, and this is the US population, it tends to be a very common category of high blood pressure. It's roughly 20 to 25% of most populations. And if you put the two of these together, it accounts for a pretty high percentage of blood pressure-related cardiovascular disease. And depending on whether you're looking at a more blood pressure-related outcome like stroke or heart failure as you get older, or a little less blood pressure dependent such as coronary heart disease, it'll account for 20 to 25% of all the blood pressure-related events. More important than capturing everyone with a systolic of 160 or above. So we felt on the basis of risk that it was an important area and an important element, couldn't ignore it. And when we looked at treatment, we felt there was very strong information from non-pharmacologic studies, including many that I've chaired, that you could reduce blood pressure in this blood pressure range and you could prevent the occurrence of so-called hypertension. And they give you typically around 3 to 4 millimeters of mercury, 2 to 4 millimeters of mercury individually. But when you combine one or more of these interventions, you can get quite substantial reduction of blood pressure that most of us would believe is beneficial for an individual. And if you look at low-dose pharmacotherapy, we have a number of trials that will show the same sort of thing. You can lower blood pressure, you can prevent so-called hypertension. And in the most recent trial that I was involved in, it's a very high-quality trial from a multi-center trial from Brazil, PREVAR. We were also able to show that you can regress left ventricular hypertrophy when you use low-dose pharmacotherapy. We didn't recommend low-dose pharmacotherapy for this situation, but it is certainly effective. Now, when you look at meta-analysis, there are many of them out there, and despite what you were told earlier, the largest and most powerful meta-analysis is this one, done by, I should disclose, I'm a co-author on this paper. It has 44 randomized controlled trials. It is what's called a network meta-analysis. It's very powerful. And basically, it shows, and I'll go into the details of this later on, that lower blood pressures are always better. And we've known that for many years, and really, it's not so much the starting point of blood pressure, it's if you're at high risk, lowering blood pressure will reduce your risk. If you're at high risk, you are likely to have an event, and one of the things you can do to prevent an event is lower the blood pressure. And it's not just this meta-analysis, there are many meta-analyses, and Dr. Brunson's meta-analysis is actually an outlier. If you were to look at all meta-analyses that have been done, there are many that have shown the same sort of thing here. Whether you're looking at all cardiovascular disease, or you're looking at stroke, coronary heart disease, all-cause mortality, whether you include particular trials such as SPRINT, which I chaired, and I think is a very high-quality trial, and I'd be very happy to debate it, and whether you do a direct meta-analysis or a network meta-analysis. You'll have less power with a direct meta-analysis, but you'll also show essentially the same thing. And once you have about 4 or 5 trials in, you're going to stabilize the estimate for reduction in risk. Now, we didn't recommend drug therapy for everyone with stage 1 hypertension. In fact, we said the core issue here is poor diet, lack of physical activity. Of course, for cardiovascular disease, you can add on cigarette smoking, but for blood pressure, it's diet, physical activity. And we said that was always going to be the core, and we thought it's a good idea for everybody to have a healthy lifestyle. And if you're elevated, to try to get your lifestyle issues in order. But for stage 1 hypertension, we said the key here was, are they likely to have an event over the next 10 years? And using a risk predictor that works reasonably well in the US, it's not perfect, but using the one that is commonly recommended in clinical practice for managing lipids, for making decisions about aspirin therapy, we didn't think we should take a separate risk predictor that's more blood pressure focused, sort of a sensible, not to create havoc. We said if your risk is over 10%, then combining drug therapy with non-pharm makes sense. But over here, only non-farm, that's about 70% of individuals with stage 1 hypertension in the US. And we didn't change from previous guidelines that have said, if you're 140 and above, it probably makes sense to use both approaches. Now, why did we say that? Well, it's actually fairly straightforward. We know that at any given level of blood pressure, there is enormous variation in the likelihood that you'll have an event. It's more than 30-fold. So if you do risk predicting at any level of blood pressure, you will see huge variability in the likelihood of having an event in the next 5 or 10 years. And if you move from a lower to a higher pressure, you'll see an increase in risk, but most of that increase is going to occur up here or here. And if you flip it and look at treatment trials, what do they show you? Well, the classic antihypertensive drug treatment trials all show you about the same relative reduction in risk, the percent reduction, the relative reduction. But if you look at absolute reduction in risk, which is what should be most important to healthcare provider and certainly to a patient, then it's those who are at higher risk that get the greatest benefit. So it's like Sullivan said, why do I rob banks? Because that's where the money is. Why do you focus on high-risk individuals? Because that's where the events are going to occur. If you take somebody who's at low risk, maybe they'll benefit from therapy over a lifetime, but they won't likely prevent an event in the next 5 to 10 years. So that's why we focused in on it. And other meta-analyses have shown the same sort of thing. When you're looking at blood pressure reduction, it's a combination of how much you can lower blood pressure, but also where is the starting level of risk. The higher the starting level of risk, the greater the impact. So both of those factors are important. And yes, it's true, and we understood this. We published the papers that have demonstrated this, that our change in the classification was going to lead to a substantial increment in prevalence of hypertension. And you can be mad with me or the rest of the guideline committee, but unfortunately, we, like you, live in a rather unhealthy society. I had dinner last night. I asked for fish, and I said, please do not put any salt in it. It's got enough salt already. I don't need more. And I'll tell you, the fish came. I had to send it back. It was extraordinarily not healthy. So we both live in societies where there's a problem with our foods and with our physical activity. So it does increase risk, but if you're saying, what about drugs? Well, we're actually pretty careful about who should get a drug. And there we have very limited impact on drug therapy. We believe our guidelines would actually have the right people get the drugs. What about the target? Well, I showed you this before, so I won't go through it again, but essentially lower is always going to be better no matter where you start with blood pressure management. It's the same sort of thing with lipids. It's really the risk of getting an event. And if you're at high risk for getting an event, which almost everyone in these antihypertensive drug treatment trials are, because we select people who are likely to have the possibility of an event, then lowering blood pressure always seems to be beneficial. So I mentioned, really we said, everyone should understand their underlying cardiovascular risk. It's not very difficult to do. Anyone can go to the ACC website or another website. It's really simple, and it's I think it's a good, sensible thing to do. And we said for stage 1 hypertension was particularly important for a therapist to do that, and only use the combination of drugs and non-pharm for those who are at high risk. We recommended getting down to a systolic of 130. We said probably a diastolic at 80 is sensible on the basis of its combination. It would be the equivalent pressure compared to systolic, but really the recent trials have all been systolic. And we said for older individuals, focus on systolic alone, because that's where risk occurs and diastolic tends to be low anyway. Now, why about elderly? I would just say in trials, particularly in HIVIT and in SPRINT, which are the trials that have had the most individuals who are older involved, we've seen a big reduction in risk. And these are high-risk individuals who are likely to have an event. Whether you're looking at, this is Sprint, we're looking at primary outcome, all-cause mortality, you'll see it. You see it across frailty. You see it across gait speed. Gait speed is a fantastic indicator of risk. Somebody who's a very low gait speed is at very high risk for an event, but they still benefit from treatment. And you see that in HIVIT as well. And we've recently presented, and hopefully we'll publish soon, an effect of lowering blood pressure. It's a secondary, it's not the primary outcome, so you have to be real careful in interpreting this, but mild cognitive impairment, which is like GFR for the kidney, is what predicts dementia for many people with small vessel disease. Mild cognitive impairment was much less common in those with the lower level of blood pressure, and the combination of mild cognitive impairment and dementia was also lower. Now, lots of people present J-shaped curves, and they frighten the dickens out of everyone. And I'll tell you, and probably Dr. Jorgensen will say the same thing, as an observation epidemiologist, I see them all the time. You give me any variable and I'll show you a J-shaped curve. And if you look at clinical trials and analyze them in an observational fashion, you will see J-shaped curves. It's not surprising. And really what's happening is the sick people down here can't mount the blood pressure. So their risk is higher, and you have to say, is it higher because blood pressure is being taken lower, or is it that they have a lot of risk and they can't mount the blood pressure? I believe it's the latter. So when we looked at Sprint, and we analyzed this according to a randomized approach, always the intensive group did better than the standard group. And we're pretty much in sync with many of the other guidelines. We may be all wrong. Maybe we're all crazy for the level of blood pressure that we should go to. And, you know, if you do modeling, you would get the impression that if you can get to these lower pressures, it would be beneficial. So I believe lower is better. I think we always have to be sensible. These are only guidelines. But if somebody like me at my age is relatively healthy and can tolerate simple approaches to improving my lifestyle, and if necessary, taking a drug to lower blood pressure, I believe that's a good thing. So thank you very, very much.